great pleasure as Chief Medical Officer of the Australian Commission on Safety and Quality in Healthcare to welcome you to the second webinar of our Better Care Everywhere program series. In the spirit of reconciliation, the Australian Commission on Safety and Quality in Healthcare acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples present today. Thank you for joining this live broadcast. Today's webinar tackles the issues of continuing increase in opioid prescribing and the harms associated with opioid use. Our guest speakers will also look at how general practitioners and pain specialists can actually work together to help de-prescribe opioids and how to manage difficult conversations with consumers and colleagues. The Commission has a national role to lead and coordinate improvements in safety and quality in healthcare across Australia. And we see that improving the appropriateness of opioid prescribing is a big part of this. This webinar is live and interactive. I encourage you to post questions and use the chat function. On the top of your screen, you will see a purple speech bar, which is labelled public chat. That toolbar can be used to talk to other attendees, but more importantly, to post questions for us in the Q&A session after the talks. So I'd encourage you to use that. There's a green arrow icon, which allows you to refresh the page if you experience any issues. And there's a red cross icon should you wish to exit the webinar. If you have problems, Redback are available for support on 1800 733 416. So today I'd like to introduce Dr. Chris Hayes, who's a specialist pain medicine physician at John Hunter Hospital in Newcastle, New South Wales, and director of the Hunter Integrated Pain Service. Opioid prescribing and harms continue to rise across Australia, but GPs and pain specialists can work together to stop the habit. Find out how to avoid opioids altogether, how to de-prescribe opioids, and how to manage difficult conversations with colleagues and consumers. Chris.
It's good to be here to talk about better care everywhere in this program series. I'm Dr. Chris Hayes, and my topic today is reconsidering opioids. A little about my background. I work at the John Hunter Hospital. I find it a privilege to be in the public system and have that less complexity that might come from patients paying for services. I work as part of Hunter Integrated Pain Service. We have quite a track record of looking at the interface between specialist practice and primary care as it relates to opioid strategy and broader approaches to pain. Our Brain Man series is one offering of interest into the space, and particularly the video Brain Man Stops His Opioids that's available on our website. In terms of professional organisations, I'm currently a board member of Pain Australia. I'm a past Dean of the Faculty of Pain Medicine and have been involved with the Pain Management Network of New South Wales Agency for Clinical Innovation over a number of years. From my early days as a pain specialist, I've always been interested in a broader and expansive approach to pain management, as is reflected in the biopsychosocial model. One does recognise, though, that there is the risk of that narrowing down to a predominantly biological focus if one pays a dominant emphasis to the first part of that, the bio. And the Faculty of Pain Medicine and other organisations have suggested the slightly long phrase socio-psycho-biomedical as a way to get away from that biological or biomedical dominance. From our team's perspective at Hunter Integrated Pain Service, we have in consumer-friendly language talked about a whole person approach, as illustrated by the 5 fingers on screen there. and you can see that opioid strategy is one component part under biomedical, but there are other parts that I would argue are more evidence-based in the treatment of chronic pain and have a greater chance to bring long-term pain reduction and perhaps resolution. The clinician going broad is one thing, but there may be in some situations a reluctance on the patient's part to change behaviour. So hence this slide is part of what really motivates me in day-to-day practice. The diagram on the left is from Susan Michi, who's a behaviour change expert in the UK. The behaviour change wheel, as it's called, with the central green circle illustrating the patient's capability, opportunity and motivation. This recognises, though, that even if the patient is not motivated or has limited capability and opportunity, that there are things that can still be done, as represented by the red middle circle that talks about what the clinician can do, and the outer grey policy circle that talks about what can happen in terms of legislation, regulation and so forth. So there are multiple words there in that middle circle. From our team's perspective, what we as clinicians often end up doing is applying a mix of empathy and boundaries. If one applies tension to both poles, both ends of the rope in the tightrope analogy, one uses empathy, which draws the patient in, and therapeutic boundaries, which may alienate them. But in using those two things together, it brings tension to the rope and allows the person to progress as the tightrope walker. All relevant to the context of opioid deprescribing and what are the alternatives available. So enough about me and my areas of interest. As we go through today's talk, I'm going to run through the scientific evidence base just briefly, really just a quick glance at some key studies from 2018. Then I'm going to talk about how this translates into practice in the Australian sector, and then look at the policy and regulation space as that is implemented at the moment across Australia. And then finally, just some recommendations, whether you be in the primary care or hospital settings. So as we look at evidence, it's worthwhile asking the question of what happens if we get this right on one hand, what happens if we get it wrong on the other hand. And there are certainly examples around the world, particularly in the United States, I think, of what happens when we get this wrong and opioids are overused. We have a lesser degree of problem in Australia, but certainly we are not problem free. I would argue that if we are not able to implement current evidence satisfactorily, this leads to an increased burden of illness for our patients. It leads to over-medicalisation and ineffective treatment. It distracts people from the treatments that really work if one focuses on opioids in the treatment of chronic non-cancer pain. 3 studies from 2018 I want to touch on. The first is the most recent systematic review and meta-analysis by Bussey et al. from 2018, as I mentioned. They looked at 42 high quality, as they classified them, randomised controlled trials, noting, however, that only 9% of those were non-industry funded. So one wonders how high quality some of these were and whether there was potential for biasing these studies in the direction of a positive response. You can see, however, the forest plot, apologies for the small figures there, but you'll be able to see from the plot that there was, when you average the results of these 42 studies, a shift to the left, meaning a representation of opioids having a positive treatment effect. However, it was only a very small treatment effect. If you average all that out, it was less than 1 point on the 0 to 10 scale. In fact, 0.69 centimetres was the amount of shift on a 10 centimetre scale. So this was statistically just significant, but we would say that that is not a clinically significant benefit in day-to-day practice. There was no difference noted in this study, interestingly, between the different categorical types of pain: nociceptive pain, neuropathic pain, or nociplastic pain. It has been argued previously that neuropathic pain is particularly resistant to treatment with opioids, but that is not something that comes up in the literature. In fact, neuropathic pain responds just as well, or depending on your perspective, just as poorly as any other types of chronic. To move to the study, it's known as the SPACE trial. This was from the United States. Again, 2018, Erin Krebs and colleagues took a pragmatic randomised controlled trial, meaning that it wasn't blinded. And in Veterans Affairs patients, they found 240 opioid-naive people who had either back pain or pain associated with osteoarthritis of the hip or the knee. And they randomised them in a non-blinded way to receive either opioid or non-opioid medications in primary care for 12 months. The mean pain intensity at the beginning of the trial was 5.4 out of 10 in both arms. What they found, interestingly, was that in the opioid group, that pain scores were consistently worse than the non-opioid group at all time points over the year. Also, they found that adverse effects were worse in the opioid group. Pain interference was no different. The study, again, 2018, McPherson and colleagues from the United States again, and Veterans Affairs patients. They took 550 people who had been on long-term opioid therapy for chronic non-cancer pain, and they discontinued them. You can see the types of pain as they classified them there, mostly musculoskeletal pain, smaller percentage of headaches and neuropathic pain. What they found with discontinuation is essentially it didn't make any significant difference to their pain. The median pain intensity before discontinuation, 4.8 out of 10, and post-continuation just marginally lower at 4.6 out of 10. The graph here subclassifies those patients into those with severe pain in the open circles, scores around 8 out of 10. Moderate pain, the triangles, scores about 6 out of 10, and mild pain in the closed circles scores about 4 out of 10. And they tracked each of those subgroups over time, and you can see essentially what they concluded, that pain either did not change or reduced slightly as people discontinued long-term opioid therapy. I think this slide very much addresses a common fear of patients when opioid deprescribing is suggested, that they might go back to previous levels of intolerable pain. This study clearly suggests otherwise. How does this translate into clinical practice in Australia? The evidence essentially says that opioids don't work for chronic non-cancer pain, and one would recognise a degree of harm as well. How are we doing in terms of translation? I would say that variability is the key problem here. The evidence that we have available is that there is a fairly large variation in clinical practice that is unrelated to the patients themselves and more related to the prescriber and their beliefs and habits of practice and prescription. The Australian Commission on Safety and Quality in Healthcare has done a substantial amount of work in this area, and their Atlas on Healthcare Variation, which has been repeated a number of times, has looked particularly at variation in opioid prescriptions dispensed per 100,000 people across different postcode areas in Australia. And this is a map from the first Atlas that shows in the darker blue areas of high opioid prescription, and then in the softer colours areas of lower opioid prescription. So one can consider what leads to the areas of high prescription. Perhaps it's the low socioeconomic status of those areas. A lot of those areas are rural and remote. There may be lack of access to alternative services being a factor as well. The Commission on Safety and Quality in Healthcare, as I mentioned, have done work looking at opioid prescription over a number of years, and you can see that in the period from when they were starting to measure back in 2013-14 through to 2016-17, that there has been about a 5% increase in the number of opioid prescriptions per 100,000 people per year. Between these last two study periods, 2015 and 16 and 16-17, there seems to have been a levelling off. It will be fascinating to track that over time. Really, given the scientific evidence being as it is, we would like to see a clear downturn in opioid prescriptions, given that most of these are for chronic non-cancer pain. In addition to the dispensing increasing by that 5% over the study period here, there has also been an increase in the clinical variation between areas of high and low dispensing. So that's gone up from 4.8 to 5.1 fold over the study period. In 2016-17, the last period studied, 1.5% of our Australian population was on an opioid on any given day, and that amounted to 3.1 million people who had one or more opioid prescriptions dispensed in that year, and that was most commonly oxycodone. To take another study, because that opioid atlas has looked more at the primary care setting. This study I've chosen just because it gives us a little insight into what happens in the hospital setting, and one can argue about the respective responsibilities of primary care versus the hospital system in creating the overuse of the opioid problem that we have at the moment. This study from 2019 looked at opioid dispensing in a DVA population, opioid naive, admitted to hospital for surgery in 2014-15. There were 24,000 of those people, and it followed them for 12 months afterwards. So 15%, just over, were discharged on opioids, and then as these people were followed, of those 15%, 3,907 people, a subgroup, relatively small but substantial when you look at the size of the overall cohort, 3.9% of those discharged on opioids became long-term users, defined as those using opioids for greater than 90 days. So as I sit back and analyse this, we look at a combined contribution from the hospital setting and primary care in contributing to opioid prescription in the Australian setting, and I think there is a responsibility in both of those sectors for us to begin to do something differently. Looking at harms, this is part of how opioids translate into clinical practice. Death being the worst harm, we can see that there has been a rise in deaths over the years. As you look on this graph plotted from 2008 to 2016, these are opioid-induced deaths, and the unbroken line at the top of the graph includes all opioid-induced deaths, as opposed to the broken line, accidental, and the dotted line further down, intentional overdose deaths. If you look at the figures in the last couple of years, opioid deaths account for about 3 people per day across Australia, which is very similar to the death rate from the road traffic accident cause. Mostly looking at these opioid deaths, they are unintentional overdoses, as you can see from the graph, and middle-aged males on pharmaceutical opioids, often with other pharmaceutical substances such as benzodiazepines, are at greatest risk. So before we move on to policy, the bottom lines: opioids are not effective for chronic non-cancer pain. There is a substantial risk of harm, and there is a substantial variation in the way opioids are prescribed by different doctors across Australia. Government are concerned about this, and so hence there have been recent changes in policy across the country. From an advocacy perspective, Pain Australia are playing an important role here in taking the voice forward from consumers and clinicians to government via an evidence-based filter. So important pieces of work in 2019 were the Cost of Pain report, a piece of work done by Deloitte Access Economics, sponsored by Pain Australia, and also the National Strategic Action Plan. So the Cost of Pain report showed 3.24 million Australians in 2018 with chronic non-cancer pain, and 2/3 of that group were of working age. So there are certainly substantial economic implications of this. The annual cost was $73 billion per annum, and there was a call in that report to support general practice education, providing more resources also to general practice, and an emphasis on multidisciplinary care. The National Strategic Action Plan is a call to government to support all of those aspects. Thinking beyond advocacy into our complex policy and regulation sphere in Australia, we have a number of groups involved in this. The Medicare Benefits Schedule obviously determine item numbers and the availability of alternate treatments beyond the pharmacological. We have the Pharmaceutical Benefits Scheme looking at medication subsidy, and as GP prescribers you will be aware of the authority requirements that have changed there. The Therapeutic Goods Administration are responsible for determining drug indications, perhaps their most important role, also product information, consumer medicine information, and recommendations to pharmaceutical company sponsors. I'll talk about their change in the indications for opioid therapy in a minute. Fourthly, there's the role of the state health departments that regulate authorities for opioid prescription in cases of opioid dependency or addiction. There's a further role under the state jurisdictions to bring in real-time opioid monitoring that's available at the moment in Tasmania, Victoria and the ACT, coming though to other states shortly. The Therapeutic Goods Administration earlier in this year changed the indication for opioid therapy to say this, that opioids are no longer indicated for chronic non-cancer pain other than in exceptional circumstances. Interestingly, they haven't defined exceptional circumstances, which means that the onus is on the prescriber, if questioned, to be able to say, why is your patient representative of an exceptional case? Looking at the evidence which leads on to what are the policy indications for opioid prescription, it's very much accepted that acute pain, cancer pain, palliative care and treatment of opioid dependency are mainstream indications for opioid prescription. Government will not question your prescribing practices in those areas. Very much different to chronic non-cancer pain. So to conclude this talk, I just wanted to focus on some recommendations for the hospital sector firstly, and then primary care. So in the hospital sector, for those of us who work there, I think this is very much about addressing patient expectations wherever we get the opportunity to, which may be in a pre-admission clinic, during the admission phase itself, and then most importantly at discharge, that we create the expectation that opioids are an evidence-based treatment for short-term pain. However, they will be weaned and ceased, and we're not initiating them with the expectation that they would be used in the long term. Another important point from the hospital system at point of discharge is that dosage should be individualised according to what the patient has used in the previous hours. I think in the hospital system we've been often very much guilty of giving patients a standard pack of 20 endone tablets, for example, when they have used no opioids at all in the last 24 hours. We need to, if we're prescribing any opioids at discharge, need to make sure that that's appropriate in the context of patients' use over the preceding hours. Third point here emphasises, I mentioned, this is short-term use and that there is a clear plan to cease, and that this plan is communicated both with the GP and the patient. Otherwise we do set up this situation where perhaps a vulnerable patient goes to the GP and says, these opioids are very helpful, thank you, can I stay on them for a long time? We don't want to place the GP in that situation. What can we do in primary care? Firstly, do not use opioids for chronic non-cancer pain, I think, is a good rule, recognising the TGA's statement that there may be exceptional circumstances where you may choose to do this, but as we look at the scientific evidence, it is very hard to discern what that exceptional case might be. I would suggest, and this is advice very much in the National Prescribing the National Prescribing Service's recommendations, to have a conversation about opioid weaning anytime you meet someone with chronic non-cancer pain on opioids. Thirdly, it is very reasonable to have some shared decision-making with the patient and negotiation in this, but the issue is to negotiate when the reduction might start and the speed of reduction, not negotiations about whether or not to reduce. Fourthly, in terms of the practicalities, I would say that a standard reduction may be a monthly step down in dose, and you might come down each notch by about 10 to 25% of the starting dose. The fact that this is a standard plan means that you would be free to negotiate some non-standard version if you wish. Clearly there are contexts where you may want to reduce much faster than this. Equally, there are some situations perhaps where patients are very fearful, where you might come down a little more slowly. And finally, if during the reduction it emerges that opioid dependence or substance use disorder is the dominant problem, then you can always switch to a drug and alcohol program and get the patient referred for consideration of opioid agonist therapy in that context. In that situation, there's much more of an emphasis on opioid maintenance for a time rather than the steady push towards opioid reduction that is part and parcel of pain management. So thank you for listening. I will be available in the next segment for questions and answers before we move on to the further talks in the series. Thank you for listening.
Thank you, Chris. That was a really fantastic presentation. I'm really going to use some of that information on my rounds in ICU when I'm overprescribing fentanyl and Tarjan and other things, which is what ICU doctors tend to do. I'd just like to remind everyone in the audience that there's a public chat button, the purple round button at the top of your screens, and we'd really love you to post any questions for Chris and our next speaker, so that in the discussion section we can be informed by what interests you and which aspects of Chris's talk hit a mark. So now I'd like to introduce Dr. Damien Zulm, who's a GP and practice co-owner at Meekatharra in Western Australia. He holds fellowships with both the College of General Practitioners and ACRRM, and has an interest in opioid deprescribing within general practice. Hear Chris and Damien in conversation as they discuss prescribing and deprescribing opioids, both within the hospital sector and in primary care. Thank you.
welcome to the next talk in the Better Care Everywhere series. I'm Dr. Chris Hayes. I've already introduced myself in the first talk. I'm a specialist in pain medicine working in Newcastle as part of a multidisciplinary team. And this morning I'm having a discussion about opioid prescribing and deprescribing with my colleague in general practice, Dr. Damien Zilm. Let me hand over to you, Damien, to introduce yourself.
Good morning all, it's a pleasure to be here and thank you for having me. My name is Damien Zilm, I am a general practitioner. I've been fortunate to work across a number of locations in Western Australia, Kalgoorlie, Meekatharra, Northern, large towns as well as smaller towns. I've been an expert advisor for the Australian Atlas of Healthcare Variation, which is the reason why I became very interested in the topic which we're discussing today. I must say that I've done substantial reflection on my practice. I've noticed significant changes to the way we actually practice with prescribing of opiates over the my 20 odd years of practice. And I think it's very, very fair to say that this is one of the most challenging aspects of general practice, and having a collegiate approach within not only the practice, but also within the community that we practice is a really, really important aspect.
Damien and I both recognise very much the changing landscape with regard to opioid prescribing and deprescribing as it affects specialists' hospital practice and general practice. We recognise that GPs occupy a complex space with competing voices from consumers, voices from the regulators, voices from the scientific guidelines, and from marketers, the pharmaceutical industry as well. I wonder, Damien, what your thoughts are of that complex space and the different pressures a GP is under.
I think probably the most important thing here is when I first started practice, it was fairly standard practice to have patients on chronic opiates, and that was considered to be okay. And I think it's fair to say we thought we were actually helping our patients. I think the evidence is now very, very clear that we are not. And this striking thing for me is the patients that I've been able to stop opiates on all say one thing consistently, and that is, I feel so much better. It just removes a lot of the fogginess and a lot of the other aspects which they had noted. And I know you're going to talk about this shortly as we go through the presentation. But it is a very difficult and challenging discussion, especially when the patients themselves believe that they are receiving benefit from the opiates. And it's not until after they've managed to stop that they actually notice that difference. And there's multiple competing aspects, which does make the job very, very challenging professionally.
So as we're thinking about defining best practice, we would advocate a systems approach. This is a complex situation. There aren't simple linear solutions. So as we look at the systems aspects, part of that is listening and responding respectfully to the patient voice. There are also aspects of defining practice policy, perhaps within your own general practice, and also perhaps developing a conversation with your own pain specialist services. How do you interact with your local team and what availability do they have? What are your thoughts about these opportunities, Damien, and that systems-based approach? Clearly it's more complicated than a simple appendicitis in general practice.
Chris, I couldn't agree with you more. My reflections are the importance of having a consistent message within the practice. So whether that's, I work in solo doctor towns, where we have a team of doctors, making certain this is a regular item which is discussed. Larger practices, making certain it's a discussion that we have within the practice to make certain the messaging, but also really importantly, the understanding is consistent. In our larger towns and obviously in Metro as well, actually having discussions amongst ourselves as colleagues. It's the consistent messaging which is really important. And as I mentioned at the start there, this is one of the most challenging aspects that we have in general practice. My reflection on myself, I know I've got strengths and I've got areas that I'm not as strong in. And I think it's fair to say that colleagues, we all have that. And it's only by working together in a systems approach that we actually achieve the best outcomes for our patients. The next vital part there, as you mentioned there, is the input of our pain specialist colleagues. And that is absolutely vital to make certain that we're getting the right messaging for our patients, also the right advice, and we're doing it in a team-based approach.
Damien, let's focus in on the patient interaction as a first part of the systems approach and consider what would you say to the patient who says the opioids work brilliantly well for me, recognising that that flies in the face of the scientific evidence. What are your thoughts?
I mean, I think that's a reasonable thing for the patient to say. That's all they've known. And if someone's addicted to opiates, which invariably is what we're looking at here, that's going to be their understanding. And so actually having a discussion, I think having a discussion with the patient, what does it mean for them? What is the evidence? But also, what is our experience? And as I mentioned there, the common experience of patients is, I feel so much better once I've stopped the opiates. And it's really a matter of engaging with that patient, I think, and having that discussion with them about what does it mean for them at the moment? What does it mean for them in the future? And what might life be? And I also reflect upon my practice with my experience, what I've seen over many, many years. That's my approach generally with it there, and then having the difficult discussions there. And I think also reinforcing each consult these same ideas and slowly bring the patient around. Some people are very readily able to accept it, but I imagine your experience is exactly the same, in that it's lots of discussions, lots of messaging. I'm just going to jump in there, however, and say this is the beauty, though, of engaging with pain specialists, is by the time we've actually managed to get the patient around to having this opinion, they're either very accepting or they're in a challenging position. And so having that advice which supports the advice that I'm giving the patient is really important. Chris, what are your thoughts to that?
One of the strategies that we use commonly, from my perspective, is balancing empathy on one hand with therapeutic boundaries on the other. And as you talk that through, I think where to set the boundary, the key issue is often a collaborative discussion between the GP and the pain specialist. So I find in my practice that's a very helpful point. Often I would resist making a definitive statement to the patient in the consultation room, and I would say, I'll have a conversation with your GP. Together we'll decide where to set the boundaries, essentially. One of the challenges about this area, as we'll move on in a minute to talk about the opioid guidelines, is that there are variations in clinical guidelines. So one set, as we'll talk through, that focus on the conversation, a longer hand conversation about opioid responsiveness, and the other set of guidelines that cut to the chase much more, recognising science doesn't support using opioids in chronic non-cancer pain, and they just go straight to let's negotiate how we're going to deprescribe, which is my personal and my team's practice. So, you know, in terms of the interaction with the GP, our phone call back to that person goes, what do you think about how to negotiate the deprescribing boundaries? Not, do you think it would be a good idea or not to deprescribe?
Chris, I must say, I love that. The team-based approach with discussion, focusing on the patient, achieves the best outcomes.
Moving to the next slide, we need to be aware, obviously, that there are different choices. Opioid deprescribing may be one important component of treatment, but what are the other alternatives? And this five-fingered, the hand approach is something that we've developed in our service, recognising the biomedical aspects, but alongside that, and this is really where the evidence base lies for pain reduction, the mind-body connection, activity and nutrition aspects, all of those things have potential to wind down a sensitised or an overprotective pain system. How do you think, Damien, those alternative strategies can roll out in a general practice context?
Oh, I think they're absolutely essential. And I mean, you can't just simply focus on opiate prescribing. It needs to be a whole of patient approach. And I suppose the most important thing there is making certain the patient actually understands what we're trying to achieve and why, because it's only then that we actually manage to make some progress. And then I find it's little by little, as we slowly achieve change, and the patient actually recognises they're not being harmed by what we're doing, and in fact they are starting to feel better.
Let's dig a little bit more into the interface between hospital specialists treatment and general practice treatment, recognising similarities and differences between the spaces, but clearly I'm very conscious of the waiting times can be a barrier to patient access. That's an issue to be aware of. I think there is something that we can discuss about how the GP and the pain specialist interact. I know variation in specialist practice. Some specialists are very happy to have a 3-minute phone conversation about opioid-related issues. Others may not wish to engage in that and feel like they need to assess the patient in person themselves before they give comment. What is your perspective from your situation in Western Australia, Damien, about that interaction with pain services?
I think probably first of all what I'd say there is, as GPs, we all do things slightly differently. There are those of us that are far more readily will get on the phone, speak to our colleagues. There are some others that would rather write a referral. So we do practice differently, but I must say my personal preference, if I can talk to somebody about the patient that I've got sitting in front of me, it makes my life much easier and we achieve a much, much better outcome. And I must say, I do notice as well the variation in advice that I receive from, yes, we should, the evidence shows that we should be reducing opiates, through to no, the patient can continue on these levels, which almost for the patient is an imprimatur to continue with where they are, even though clearly it may not be, I think, in the patient's benefit. And I suppose this then really comes down to is what makes a good referral. I mean, apart from having a nice, tidy, succinct past medical history list, up-to-date medication list, I think that what's in a good referral is what questions do I want answered? What needs to be the focus on the discussion for the advice that I need back, and what are the priority areas, and also the discussions that I've already had, which I think really lets you know as a pain specialist what I'm trying to achieve and what help I think we need with the patient. And you can also then see where I might have missed something there or what additional input and advice that I need. I don't know, what are your thoughts on that, Chris?
Yeah, I strongly agree with that. It makes my task much easier if it's very clearly expressed what the GP wants, and I don't have to read between the lines or make guesses. If it's a fairly generic referral, I'm left wondering, what is the GP really wanting in this situation? What does the GP want from me? So yeah, clear articulation is good in that setting. I think in the COVID cloud, one of the silver linings perhaps is this encouragement for all of us to look at different ways of accessing different parts of the healthcare system. So it's good to consider between the GP and the specialist the role of telephone or email, telehealth, as well as the patient coming in person, which has a place, but perhaps we shouldn't consider that's the only way of doing business. And also I would add, what makes a good referral from my perspective is if the patient's expectations align, or at least approximately align, with what we're offering in a pain service. So if the patient comes in aware that the pain multidisciplinary team will be supporting them in their endeavours to come down off medications for chronic pain and to explore a more supportive and active self-management model, that is making the behaviour change so much easier. Let me, on this next slide, Damien, I just wanted to reflect on some of the outcomes achievable at a specialist multidisciplinary pain clinic, and then for your comment about the challenge of applying multidisciplinary care in general practice. These results are a 5-year period from our Electronic Persistent Pain Outcomes Collaboration, or EPOC, data set. And it looks at patients over that 5-year period who came into specialist systems on opioids and who we also had an outcome data point at the end of treatment. So we had 6,300 patients in that group, and I've taken, as you look at the table there, change scores in terms of pain severity, pain interference and pain self-efficacy. In the first treatment column, those who ceased opioids altogether, compared to those who reduced by 50% or more, compared to all the others. And the key point I wanted to make is that the outcomes in all of those areas, the change scores, were most positive in those who ceased taking opioids altogether, the next best outcomes were those who reduced opioids by 50% or more, and the worst outcomes essentially were in those who made more minimal change or maintained or perhaps even increased their opioids. So clearly this is what's possible with the allied health multidisciplinary resources in a specialist hospital clinic context. What do you think, Damien, about applicability? Clearly this is one of the challenges in the different setting of primary care.
I mean, I think that the most striking thing for me is, for some of my colleagues, this will probably be new information. This is not what our understanding typically used to be. And I must say, as I said, I used to think I was helping my patients by continuing on the opiates, thinking they actually was giving them some benefit. Clearly, this shows that they are not. And I think there's going to be a fundamental shift in terms of general prescribing practices over the next 5-10 years. And I think we're going to see a substantial reduction.
I mentioned in my first talk the Therapeutic Goods Administration change in opioid indications for chronic non-cancer pain. So now they would say opioids no longer indicated for chronic non-cancer pain other than in exceptional circumstances. So as we look to opioid use in a general practice setting, what works in your practice? I guess this is on the back of the evidence, which would not demonise opioids, but say there's still a role for acute pain and cancer pain in palliative care and opioid dependency, but we need to be very measured in chronic non-cancer pain. And although TGA has put out the exceptional circumstances term, there's been no clear definition of that. What do you think?
To me, it's clearly understanding what the evidence shows. And whereas previously it was deemed to be acceptable practice to continue somebody on opiates if you thought they were getting benefit, clearly the evidence is that there is no benefit at all to my patient. And so actually having that discussion, setting the expectations of how it'll be used and how it's going to be reduced, and a stopping and a cessation date, I think those are really important discussions to have at the very outset. So quite frankly, we're not starting on patients on this long term. And I think that's the difference that I have seen in practice over recent years.
Let's move, Damien, to look at the guidelines, because we noted clinical variation in different doctors in terms of their prescribing patterns. There is variation in guidelines, and as we've developed these slides, we're noting two different types of guidelines. The first set of guidelines, as shown on the slide here, that focus on an assessment of opioid responsiveness in the clinical unblinded context. So this, I would say, from my perspective, leads to a longer form conversation with the patient about what benefit and what harms do you perceive. So as we dig into this, I would say that the Faculty of Pain Medicine position statement, the College of GPs prescribing drugs of dependence in general practice, and the United States Centers for Disease Control guidelines all fit into this. They do, all of them, mention the fact that opioids are no longer first line, but they also all allow a certain amount of wriggle room to say, in some situations, the patient may report greater benefit than harm, and then the implication is that maintenance therapy is warranted, recognising that flies in the face of the scientific evidence. So I'm just showing those slides briefly. The faculty guidelines, the College of GPs and the CDC guidelines, that all allow wriggle room. Do you want to comment briefly on that, Damien, and then I'll move to the next bank?
Yeah, I've reflected upon the difference in practice, and I think what it is there is that our patient management isn't as up to date as what the evidence is. And as I've mentioned, we're seeing a shift is what I'm noticing. And I think that wriggle room does make it easier and allow professional decision making to occur with a patient. But I think clearly we can see exactly where this discussion is heading, and I think we're going to be in a different situation in the next 5 to 10 years.
I think the reason why we've differentiated into two blocks of guidelines is that it gives a GP or any prescribing doctor some choices. And I have my own personal bias here, but I'm not trying to steer people into one group or another necessarily, but let me just move to present the second bank, one of which comes from my team, Hunter Integrated Pain Service in Newcastle, but alongside guidelines from the NICE organisation, National Institute of Healthcare and Excellence in the UK. The first NICE guideline is from 2016, a guideline for low back pain and sciatica, which says don't prescribe opioids for chronic non-cancer pain. Their more recent guideline is a draft form at the moment directed at chronic primary pain, which basically looks at primary pain being that which relates to pain system sensitization rather than a secondary cause such as osteoarthritis. So they say in that although antidepressants can be considered, do not offer paracetamol, NSAIDs, opioids, antiepileptics, benzodiazepines, local anesthetics, ketamine, corticosteroids or antipsychotics. This slide shows our Hunter Integrated Pain Service guideline, which says do not initiate opioids for chronic non-cancer pain. If someone's already on them, aim to deprescribe. Share the decision-making about the timing and rate of reduction, but not about whether you're going to deprescribe. And non-pharmacological alternative treatments are available as an option if the patient chooses to engage. So, yeah, it's interesting, Damien, isn't it, in terms of there are benefits perhaps for the GP in terms of having a bit of wriggle room. There are also perhaps benefits in holding tightly to the boundaries, and I think people do have a choice there. What do you think about that?
I absolutely agree. There is a lot of wriggle room and ability to make decisions. I think as the evidence comes across the whole of the profession about the no benefit of opiates for non-cancer pain, I think that's going to become far more standard practice in terms of how we practice as a profession.
Let's move to the policy aspect and look at the role of the Therapeutic Goods Administration. As mentioned, they've changed the indications recently to define, or not to define, but to mention the exceptional circumstances rule. They've put out an information sheet that raises the possibility of, from a safety perspective, getting anyone who's on a morphine equivalent oral dose of over 60 milligrams down to under that threshold. So this is part of the changing landscape. Let me also highlight the Pharmaceutical Benefits Scheme changes to authority requirements from the 1st of June 2020 and further 1st of October 2020, really both working towards reducing harms by reducing duration of treatment for acute pain and also reducing the number of people on prescription opioids for long-term pain. How does that feel from your perspective, Damien, in general practice, the tightening of the regulation process across the country?
It is absolutely beautiful. And I know it was a challenge when this came in at sort of what seemed like fairly short notice for a lot of my colleagues. But the key thing here is there is now consistent messaging across basically every area about opiate prescribing. Very, very clear signalling both to me as a professional, but also to my patients. And I can actually use that as a discussion for my patient, because the key thing is having the patients understand that this is actually not going to be helping me in the long term. This is not something which we should be starting. And what are our options? And actually having that as a front and center discussion that's understood by all, I think is the key issue here.
There are some excellent resources that have been developed. I think the National Prescribing Service has put out some excellent material that perhaps may be in contrast to the marketing of pharmaceutical companies, so we would highlight that. And also a mention in the policy landscape of real-time prescription monitoring. So this is available at the moment in certain, but not all states and territories. SafeScript provides a good example in Victoria. There's been a long-running scheme in Tasmania as well as one in the ACT. What is your perspective, Damien, about real-time monitoring and the potential that that has?
I must say, I don't yet have that in WA. I'm really, really looking forward to that coming into play. The access to resources that I have is somewhat more limited. I think having real-time prescription monitoring is going to make a really big difference.
So as we summarise and wrap up our conversation, I think we would emphasise the importance of the different layers of the system. So that doctor-patient conversation, clearly very important. The way we work together from the general practice to the hospital specialist setting is important. And the policy changing landscape, very fascinating. So overall comment on policy as we move to close our discussion, Damien, help or hindrance, would you say? Some doctors may see this as interference with their personalised practice. How do you respond?
We have very strong evidence, and if we're following guidelines in evidence-based medicine, this now all perfectly aligns.
Thank you for listening to our conversation. Up next, we have some time for questions and answers. Please bring your interested comment and questions.
Thanks, Chris and Damien. Clearly, we're all in this together, and we need to collaborate and have a coalition of the willing to help these patients come off their opioids. We're about to go to a question and answer session. So for members of the audience, there's a purple button on the top of your screen labelled public chat. If you have questions, Chris and Damien, if you could put the question in the public chat area, and hopefully we'll be able to get to the questions. So I've got a series of questions here which are really actually quite insightful, and thank you for them, and we'll look forward to more questions coming in as we go. So the first question is, why do some people like to be on an opioid when it's the evidence suggests the harms outweigh the marginal benefits? Chris and Damien, your views around this?
Perhaps, Robert, I might kick off and then see how Damien responds. But from my perspective, we now have a clear evidence base that opioids don't work over the long term in terms of the pain aspect. So we do start to wonder what might the benefits be, what makes the medication likeable for the patient. There are a lot of opioids in the limbic system, I think, is one of the key issues here. And people who have a certain amount of psychological distress, deeper turmoil, often find that that blanket of opioids or perhaps other drugs such as benzodiazepines calms those inner fires, which I think does relate, as I mentioned, to opioid receptors in the limbic and related areas that are to do with emotional regulation. Damien, what do you reckon?
I think thank you, Chris. I think it's a fairly simple answer. The person has the belief, well, I have pain, I'm on a painkiller, therefore my pain is better because I'm on a painkiller. But we all know that the evidence is that it doesn't work like that, and all it does is it causes dependency. So I think that really what we see is the situation of the person actually not knowing any better and having a belief that I should be on this painkiller because it's helping me. And I think as a medical profession, we have only really come to that realization fairly recently that opiates aren't indicated for non-cancer pain. Certainly, I know a few years ago, I thought I was helping my patients. But clearly, I now know that by reducing weaning, the patients get a significant benefit. That clouded kind of foggy impression that they have in their thought process goes away once they've actually managed to stop that. And so that's a discussion I have with all of my patients. And that's the key thing which I emphasize to them is once we've been able to stop there, the significant benefit that they feel.
So you tap into the placebo response there, I think, which is a component part of this. Damien, I absolutely agree. And interestingly, that we start people on opioids without any blinded trial, the placebo or another active agent. Food for thought.
Thank you very much. In the new TGA regulations, there's a comment that opioids shouldn't be used for chronic non-cancer pain except in exceptional circumstances. Can both of you describe for us what these exceptional circumstances might be?
This is a difficult question. Damien and I were batting it back and forth earlier. I think both of us were agreeing in our clinical practice, there are few to no exceptional circumstances. But Damien, do you want to describe your practice?
Yeah, okay. Thank you, Chris. I'd probably say that I don't think there are really any exceptional circumstances. I have patients that are very resistant to change. Certainly our elderly patients that have been on opiates for quite some time, I worry about the falls risk for them. And I think things need to be done carefully. I think when we're treating osteoarthritic pain, trying to reduce during winter months is going to be more problematic. And I find it's far more difficult to be able to do it during the winter months. However, having the discussion of the benefits and doing it over summer, I find that actually is far, far more successful. Yeah, so I don't think there are really any exceptional circumstances. There's more resistance. And as I mentioned before, my thought there is a person actually not understanding the difference between dependency and that there actually isn't any benefit of the opiate medications. Chris, what's your experience?
I wonder and think about the grey zones, if you like. I'm not sure whether they quite constitute exceptional circumstances or not, but if we think about the evidence-based indications for opioid therapy, those being treatment of acute pain, treatment of cancer pain, and treatment of opioid dependency, then there's the grey zones as the situation abuts onto that. So perhaps the acute pain patient who has a complex trauma, pelvic fracture, something like that, and psychological comorbidity, one might be tempted to go on longer than the 3-month mark with opioid prescription at times, which would then take it into prescribing for non-cancer pain. Having said that, I think mostly the negotiation should have drawn the opioids to a close before that. I think with regard to opioid dependency, there can be debate back and forth as to how much the drug might be for analgesia and how much it might be for opioid dependency. I think that's a good discussion to have and to try to be clear about, but there may be some patients who end up on some sort of de facto drug and alcohol program where the opioid is on the surface for pain. I think also the elderly, there was another question in the chat that we might or might not get to later about a gentleman in his 80s who hasn't responded or has had side effects from ibuprofen and paracetamol, but seems to be doing okay on the buprenorphine patch. I think the elderly and that transition to end of life settings is another grey zone, which really is about when do we say someone is palliative? You know, there's the narrower definition of someone who's likely to die in the next month or two. Opioids are clearly indicated there. If we look at people who are expected to die perhaps in the next 12 months, it becomes less clear. So maybe that could be a grey zone. Clearly, we're not after the same improvements in function in someone who's expected to be dying within 12 months. So to my mind, they're the grey zones. Perhaps there might be exceptional circumstances in that. Broadly, however, in our clinical practice at a multidisciplinary hospital clinic in Newcastle, we tend to deprescribe or recommend deprescribing for everyone we see with chronic non-cancer pain.
Chris, I just want to add something there as well, because I think it's really important. Setting up patients' expectations is really, really important. If at the time of initiation, the patient, we have the discussion as clinicians with the patients that there isn't any long-term benefit, that there is only short-term benefit, then we can really change the situation of actually not having the patient in a situation where they are going to be on opiates for an extended period of time, because they know that all that's going to lead to will be dependency. There's a planned initiative of starting and then of weaning, which really starts in the hospital and then continues into the private practice setting as a collegiate environment.
I know, Damien, you and I very much agree on the concept of the teamwork between the hospital setting and the primary care setting. So I absolutely agree with what you're saying. We need to, if we're initiating opioids in the hospital system, flag that deprescribing will be happening and cessation will be happening, sets the course, makes it easier for the GP, and the communication between hospital and GP. That telephone call, if that's the way we communicate, is very valued. Sometimes the electronic discharges fall through, or they can be a useful mechanism as well.
Okay, thank you. So talking about multidisciplinary teams, there's been quite a few questions around what the place of the community pharmacist is in helping with that. And so apart from the GP and the hospital, who else could help with this multidisciplinary approach to deprescribing and getting people off opioids?
Damien, do you want to kick off on this?
Yeah, thank you. I liked that question. And there was also a question that brought in the remote context.
No. And so that's the second question, which was coming in a minute, for you to answer about how you get on when you're in the bush.
So I might answer, because I see this as part of the team, and I think this is actually really, really good. And it's having those collegiate discussions with your colleagues, making certain that you're all managing things consistently. You're giving the same message to the patients as well. I mean, that makes a really, really big difference. I've got really good relationships with the pharmacists. I'm quite happy to get on the phone, give them a call, have a discussion, and I'll regularly find some additional information that I wasn't aware of from the pharmacist about other bits and pieces that I may not be aware of, other buying patterns the person might have in pharmacy. And it just helps to really have everybody on the same page, because the pharmacist will then start reinforcing the messages and what we're trying to do. And as I said there, in the remote context, if you've had that discussion and you're working really, really well as a team and you've built that, that discussion then becomes so much easier because the patient's hearing the same thing from multiple different people. And the other thing which I find then is those people that are quite resistant at the start, after a period of time, they're hearing the same message, and it becomes so much easier to then look at deprescribing. Chris, what are your thoughts?
Yeah, I see less from where I sit in the hospital system in terms of practical linkage to community pharmacists. I don't particularly do that unless someone was forging my signature and taking a prescription into the local pharmacy, which has happened once or twice. I had a recent discussion with a colleague in the UK, which was of interest to me. She's a specialist in the hospital setting in Southampton, and she was commenting about the role they have in the UK, about community pharmacists who play a major role in planning and really often leading the process of deprescribing opioids in the system there, although I think our system in Australia is a little different to that. But I think your comments are well made, Damien.
Okay.
Robert, can I just jump in? I've just seen a question which has popped up there, which is a practical way to approach colleagues who continue to prescribe opiates for non-cancer pain. So I hope you don't mind me jumping in and answering that one. Look, that one I found really, really difficult. But normally what it is actually having collegiate discussions in the environment. I worked in a couple of larger towns, a couple of practices where there were a couple of exceptions of people that management was difficult, which then became really problematic when that person went on leave. And then I was required to be continuing a management plan for patients with the expectation that I would just continue prescribing. And that was a difficult challenge. And it was only through having a collegiate discussion with all the GPs, some of it one-on-one. I think that's the only way of being able to do that. Remembering we're all working as a team here together.
If I can just add to that, Damien, from my end in the hospital pain clinic setting, it is incredibly helpful if there is a practice-wide policy in the general practice. I guess it depends somewhat on the nature of the general practice and the relationship between the doctors working there. But to me, it's all benefit and no downside if they were to meet and figure out a practice-wide policy. I guess you could say the same for tertiary pain clinics as well. There are some where different doctors have different approaches. I know our team has spent a lot of time working together, so we are pretty tight on message, and all of my medical colleagues and also my allied health colleagues will say the same thing about the opioid strategy.
Okay, thank you. There have been several questions about patients who have intercurrent mental health disorders. The questions are twofold. One is, how do you approach someone who's got an opioid dependency and a mental health disorder? How do you deal with that? And the second aligned question is, how do you deal with a patient who's known mental health disorder, who comes to you demanding opioids and won't take no for an answer?
I think we can bounce some responses back and forth here. There's not an absolute answer, I don't think, but yeah, I would make the point that opioids don't help and probably harm mental health disorders. So I think just the fact that someone has a mental health disorder doesn't let us off the hook medically. We shouldn't be prescribing an ineffective treatment that may add to their difficulties. That said, I think anxiety is obviously a very common mental health disorder, and that fear factor is a big aspect that we need to address in opioid deprescribing. So our team's approach is to just go slow in that setting, and that has a number of advantages. We're trying to find a speed of reduction that doesn't freak the patient out. We're also allowing them the opportunity to interact with some mental health professionals or with their GP to address the underlying mental health problem. I think slow would be my lead answer there. And there was an aspect, Robert, you were asking about the opioid dependency aspect. To my mind, that is a question well worth considering. Broadly, it splits that if the main problem is deemed to be pain, then we're always going to be recommending slow deprescribing. If perhaps during that deprescribe it emerges that the primary problem is opioid dependency or opioid use disorder, as we might call it, then sure, the person could be transferred to a drug and alcohol approach, which might be liquid methadone or buprenorphine in its various forms, including these days the depot injections. That's my take. Damien, how does that work its way through the mental health tensions in primary care? Because in a way you're in the hot seat. I can just make a specialist comment and bounce the patient back to you, and you have to look after them over the long haul. What do you think about that?
I don't know if you saw just how the smile that I had when Robert read that question out. I'm going, yep, we've all been there. The challenging and really, really difficult patients. Look, I'm absolutely in agreement with what you're saying. Carefully, go slowly, consistent messaging. The one question which I would come back to, though, Robert mentioned the demanding patient. And I suppose in that situation there, discussion regarding boundaries, about a therapeutic relationship for the patient, and what's actually happening. It's easier in a small town where you're working together and you can actually have those discussions about where the boundaries are and what you will do and what you won't do, and then having consistent messaging. But yeah, invariably it's negotiation, which also, if it's inappropriate, might be a no. Which then has its own management issues as well. But that can actually be a very, very strong message to the patient as well. But yeah, I think to answer the question, go slowly. And I absolutely agree with your suggestions just then of how you approach it.
The strategy I would teach to our registrars and team essentially with the difficult consultation is, which I mentioned at the first part of my talk, to combine empathy on one hand with boundaries on the other hand. I've found just being very intentional about both of those aspects is fundamental. So on the other hand, if one is overly empathic but without boundaries, or too much boundaries and not enough empathy, one can get into trouble. Too much boundaries and not enough empathy, the patient disengages and gets angry and storms off somewhere else. Too much empathy perhaps and not enough boundaries, you might be inclined to follow their wishes to increase the opioid dose. So the trick is to be empathic, gain an understanding of their situation, and then say, what I'm going to be able to offer you is this, having listened to your careful explanation of your situation. What I can offer is this, and bring in your boundaries. So I think that seems to resolve or wend a way through without dragging the consultation out too long, because we don't want the difficult consultation going on and on and on and filling your waiting room up with more patients.
Just thinking about that as well, just to add, there is another dimension here as well. Our mental health patients that are on opiates are a high risk group patients. the risk of overdose, of death. This is a group that I'm far more concerned about, and will go to a lot more effort to have those discussions, to get engagement from the patient, to really discuss the benefits, and especially from the point of view of how they feel once they're actually off the opiates. That's one of the critical things that I will emphasise with them. To me, it's building that relationship and going slowly.
Okay, thank you very much. There's been quite a few questions around how you get allied health supports for your deprescribing. So psychologist visits, physiotherapy visits to enhance muscle strength for your osteoarthritic patients. Do you have any comments around how you enlist your allied health colleagues?
I think this is probably mainly a question for Damien. I know I'm very spoiled in this regard in a tertiary hospital John Hunter setting with a multidisciplinary team that I work as part of. So we have that very much on tap, and I would say that is absolutely fundamental for us. In fact, what we mainly do as a team, I find my medical colleagues, is earlier in the patient journey. Often it's discussing opioid strategy with the GP, and then once that aspect of care is sorted out, it's really over to our allied health team for the real pain treatment is how we would approach that. It's really the psychological, the social, the physical activity and the nutritional aspects that are where the real pain reduction and benefits happen. Damien, how does that translate? It's a different context, I guess, the primary care setting. How do you go for accessing physios and psychologists and others?
I mean, first of all, what you have is gold standard, and being able to replicate that in the community can be a little bit challenging. But by the same token, it looks different wherever I've worked. It's a matter of knowing what resources you have, getting the patient engaged, and having a clear plan in terms of what you're going to do, clear patient expectations in terms of their side, as you were saying there before, their discussion with the GP, setting that aspect of how's the pain management going, what's going to happen from the pharmaceutical side of things versus the non-pharmaceutical side with management, getting the patient on board with what you're hoping to get from each of the allied health inputs. It's pretty much the same as what you have. It just looks different, and obviously takes longer to organise. It's not as if psychologist might be somebody. One of the locations I worked at, that can be several weeks away, even longer, depending on what options that I've got there. But it's a matter of having that discussion with the patient and working out something that's in their best interests, and having them engaged with it.
I think also I would add, in this day or the post-COVID era, even more so than pre-COVID, there are a lot of online resources that might play an interim role there. So there is some good website resource material around from multiple organisations that may fill that gap until they see a psychologist. And I know I would often suggest things from our teams or other websites for people to look at, and then take that into the discussion that they might have with their psychologist in primary care.
So from a pain point of view, do you think patients have enough access to psychological services?
Damien?
Yeah, thank you. I'll jump in this one there. Difficult, especially where there's lack of access. There's lack of access for a number of aspects within mental health and psychology access in the community. I don't know that we'll ever have enough of what we have, but it's a matter of managing what we do have. And I mean, the other key thing there is I, as a GP, can help with some of those aspects as well, and really work hand in hand with the psychologist. And again, maybe having a discussion with the psychologist afterwards or before or something like that, just to set up the range of expectations of the patient. And so we're actually working as a team. I think that's probably the key thing here.
I would add, Robert, that the Medicare Benefits Schedule review is currently before government, and I know there has been a suggestion to increase access to allied health services, including psychologists, for the management of chronic pain. It will be interesting to see how that request is received. Although even with that and increased access to Medicare item numbers, there's still the issue. A lot of patients talk to me about the gap payment. So the Medicare reimbursement isn't enough to cover costs essentially. And there is a substantial gap payment usually that the psychologist or the physio would add on top of that, that makes it difficult even if the visit is covered by a GP management plan or like.
Okay, thank you. Here's a question for you, Chris. How do you handle the issue of a physiotherapist requesting that you prescribe opioids to allow them to mobilise a patient? Do you prescribe the opioid or do you resist?
We would resist. There is a debate in physio world and beyond about the window of opportunity. And I would argue that the window of opportunity is something of a myth. I can't remember the gentleman's name. There's a physio, I think, from the UK who writes in a very articulate way about, is there a window of opportunity created by either opioids or other drugs or perhaps procedural interventions? He argues not, having reviewed quite a bit of the science. I think, you know, even if the opioid were to work a little at first pass, our team's experience is that it really trains the patient in passive receipt of treatment rather than active pursuit. So really one wants the patient to be able to work with their existing level of pain, and that might mean starting the physical activity very slowly, but to band-aid the pain and artificially lower it to start a physical treatment program, I think, is unnecessary. Yeah, we would certainly not agree with that view.
Okay, thank you.
Actually, perhaps further what I could say to that, Robert, is if that request did come in, I would get one of our physios on team. We have 3 fractional appointments. I would get that physio to perhaps talk to the physio in primary care and discuss the strategy and how we would usually manage that.
Okay, thank you. There's been several questions about whether opioids are appropriate to manage patients while they're waiting for surgical intervention, say an orthopaedic surgical intervention for osteoarthritis or for rheumatoid arthritis of a joint. So is opioid use in that setting while you're staging someone waiting for their surgical appointment to come up, is that justified?
That can often be a slightly difficult clinical discussion, I find, which hinges somewhat on the length of the waiting time. How soon will surgery be happening? And what I would tend to do, if the surgery is a long time ahead, I think that is plenty of time to wean the patient down and perhaps get them off opioids. There is some evidence to suggest that the outcomes of orthopaedic surgery, joint replacement, etc., are worse if someone goes into that on opioids. So that's my preferred approach. However, if the wait time is relatively short, you've got to factor in the disruption to the patient and the emotional angst that might come with deprescribing. We want people calm going into surgery rather than distressed. And we certainly don't want someone going into surgery in the midst of an opioid withdrawal state. So pragmatically, if the waiting time is relatively short, I would often chat to the GP, and maybe we're more likely in that situation to consider opioid maintenance and then return to the deprescribing emphasis in the post-operative phase. Damien, I don't know if you want to comment from your GP perspective on that.
Most of the patients that I've had have been already on long-term opiates. Surgery is approaching. It's a really difficult and challenging discussion to have, but your approach is exactly, I think, what should be done, and that's what I try to do. But there is often resistance, and a lot of resistance.
There are some weaknesses, I think, Robert, in our hospital systems, probably in the way we approach that. I know at the John Hunter we have relatively long wait times, phase 1 for the patient to initially see the surgeon, and then a phase 2 wait having seen the surgeon to get the surgery. And so essentially there can be a lot of time wasted perhaps there, maybe up to 2 years where there isn't necessarily, at least initiated from the hospital, an active management approach put in place, but we are having conversations about can we do better there. For instance, if there was a multidisciplinary input early, then opioid deprescribing could be part of that. It could be supported by some dietetics input, weight reduction and physical strength gains, and then you may even find that half of the people on the wait list for hip arthroplasty or knee might not in fact need that surgery. We can do better in the hospital system for sure.
Yes, I'm sure. There's a couple of practical questions here. One is regarding fentanyl patches. How do you practically deprescribe, say, a 75 microgram fentanyl patch? How do you do that when the next patch down is 50 micrograms? That seems a big jump. What would you do in that?
Perhaps I'll take that, Robert. There is a 12 microgram patch as well. So my typical approach is to come down in monthly increments. That could be varied if the patient was particularly anxious. You might make the step down every 2 months rather than every 1 month, for example. But I would step from the 75 to a combination of the 50 plus 12. So a 62 mic dose for a month, say, and then down to 50 for a month, then down to 37, which would be a 25 plus a 12 for a month, then 25, then 12, and then you can at the bottom end, although the pharmaceutical company don't recommend it, cut the 12 mic patch in half, which delivers around a 6 mic dose. That's equivalent, if you multiply that by 3, to 18 or 20 milligrams of oral morphine equivalent. You could, if you wanted to, and if the patient was at that point not wanting to come down and stop off that dose, you could transition them, for example, to a Targan dose and just slow the back end there by changing them, say, off the 12 mic dose to a Targan 5/2.5 milligrams twice a day, and then halve that dose and then come off that.
Okay, thank you. Another practical question is, how do you deal with people who are on regular background opioids plus PRN opioids? Do you attack the PRN first, or do you attack the background opioids first, or both?
I don't necessarily have a fixed view on that. I will get Damien's comment in a minute. Often I would say to the patient that I need to talk to your GP before we close this deal. So it would often be a phone call with the GP as we decide on that, informed by the patient preference. So personally, I don't think it matters. I think any reduction is good, and you can argue it either way. Some patients are particularly attached to the short acting, and they are happy to start with the long acting. So I would tend to favour that for some. On the other hand, and perhaps if there are particularly problems with misuse, dependency, one could argue to bite the bullet and get rid of the short acting, which is their most favourite first. Could go either way. Damien, how does that work in general practice?
Yeah, I have the same experience as you. And I find, the key thing is having the discussion with the patient and getting them on board and then following the plan. I think the crux of the question really is, if I reduce the daily opiate long-term, the slow release that they're on, that is going to increase the immediate release as the PRN. And so effectively there's been no net reduction. So it's really actually tackling that as the central issue, and then negotiating further on what the reduction actually looks like. And then finding the reasons of what the patient's belief is in the PRN versus the slow release. That's at least my standard approach. And I find that to be quite successful. I think that aligns with what you were saying.
I think that's a point well made, Damien. It's the total daily dose that is the most important thing. No value in coming down on one or other and have the corresponding one go up.
I guess another practical questions come up around availability of pain management services, and often they're quite difficult to get into. And some of the people on the video conference are concerned that it's often some months before they can get their opioid dependent patients into a pain management service. Do you have any advice for how people who aren't as experienced as you, Damien, should manage that situation?
I've sometimes quite often getting on the phone and getting some verbal advice first of all. I mean, a service like Chris runs is absolutely exceptional, but there's normally, you can call a colleague, you can certainly discuss, so as GPs, with other colleagues that we can talk to. There's certainly the option of going through pain management and getting just simply some verbal advice. I think the key thing really is in terms of what you're trying to do. If you've got a consistent message, which is that opiates do not work for non-cancer pain, and you're having that discussion with a patient, you're setting the expectations, that's going to make it much, much easier. Quite often, I think some of our patients think, well, pain management might well say, look, I should be continuing on this dose. And so I think it's really a matter of making certain it's multidisciplinary, you're getting advice, you're working with your colleagues, and you've got a consistent message and plan for discussion with a patient. I think I've answered that question. Yeah.
No, I think you have, Damien. I was just going to add to that, one of the principles I think you're raising, at least in what becomes a difficult conversation, is to take it out of the room. And I would often say that to a patient who's rolling their sleeves up and getting a bit argumentative with me, to say that I'm not going to make a decision now, which really unsettles them in a potentially helpful or unhelpful way. And I'll say, look, I really need to have a discussion with your GP about this, and together we will decide what is happening. Bye-bye. And then they leave the room feeling unsettled. But I think that's a useful form of unsettling, because it gets them considering the alternatives. And, I think that's a good tactic for the GP as well. It's a difficult situation, particularly if you're a solo GP feeling under pressure from a Friday afternoon threatening male patient. But I think the advice is good. Take it out of the room, tell them you're not going to decide then and there. You need to speak to a colleague, which could be a general practice colleague, it could be a specialist pain service. I know we do a lot of telephone chat to GPs, and often that chat means that the patient doesn't actually need to come into the service. Our team are very comfortable working in that way. I think it's a good use of the medical resource of specialist teams. Essentially we're wanting, I know we talked in the discussion about what makes a good referral. It's useful for us if we can do mostly the opioid negotiations by telephone with the GP. We want a well-prepared patient coming into our pain clinic who is recognising that our team will support the opioid reduction that the GP has started, and they want further input from our team to help with the multidisciplinary self-management aspects of their problem.
I might just add to that. There's also, I've just been reflecting what we do in our practice, and we've got a registrar in our practice, and one of his approaches consistently is, I need you to see one of the senior GPs as well. So you're getting that collegiate supportive opinion, and because there are several of us which do rotate, and although it's certainly Meekatharra is a solo practice for a lot of the time there, we do work together well as a team, and so you can ask the patient to see a colleague who's going to have the same message. They're hearing it from a slightly different perspective. And I find that collegiate environment, I think, is definitely the best way of approaching this.
And I think for the highly demanding patients who may be skilled in the subtle or not so subtle art of manipulation, we are, all of us medically, in that one-on-one doctor-patient situation, vulnerable. So to be able to close the consultation, walk out the door, out of the manipulation zone, take a few deep breaths, and all of a sudden you start to see things more clearly, I think, and with a different perspective in the heat of the consultation. It is very difficult to think rationally in the face of a lot of distress.
Absolutely agree.
Thank you very much, Chris and Damien. I think that was a really fantastic question and answer session. And clearly we are all in this together, and if we're to deprescribe, we all need to collaborate and be collegiate and work with the one voice. So I'd like to thank the steering committee that's helped us set up this conference. I'd like to thank all the members of the commission that have made tonight and this seminar possible. If you have any questions that, which we've had insufficient time to answer, you can email the atlas at safetyandquality.gov.au and we'll attempt to answer them. The website in the next day or two will have the videos and the question and answer session and the slides from this presentation today for you to use. And I think some of these will be really useful for in-services, for staff and for colleagues. The Commission is able to give CPD certificates should you wish to have a CPD certificate for your self-directed learning. And you can get that again by just emailing atlas@safetyandquality.gov.au. This is the second of a series of webinars. There's another webinar on Thursday night around opioids in hospital practice as opposed to general practice. And next week we have another seminar around variation. So I'd encourage everyone to enrol for those. As I said, tonight's presentations will be up on our website for you to use for your education and your colleagues' education. So I'd encourage you to use that. So thank you everyone for your participation. Thank you for your questions, and I wish you well.